Thank you, Irfan, and again, thanks again to the organizers for including me in this wonderful meeting. For this morning, I was asked to speak about ocular genetic conditions not to be missed. And what are genetic syndromes you shouldn't miss? Well, let me first say that there are literally thousands of syndromes that involve the eye, and we're not expected to know them all. My goal today in the next few minutes is to highlight my experience with some selected syndromes that can present early and first to the ophthalmologist, and for which early recognition decreases morbidity. These selected cases can be considered genetic syndromes you shouldn't miss. So time is limited, so let's get started. Here's a 4-month-old boy, the fourth of 4 children. Parents are not related. He's referred for nystagmus. You examine him, he has no iris, he has a lens opacity, he has peripheral keratopathy, he has no fovea. The diagnosis is not in question. He has classic aniridia. And that's not the condition, though, that I'm worried about missing. What we're worried about is whether or not he has another problem that sometimes is associated with classic aniridia, that is mutation in the gene next to PAX6, mutation in the gene next to the gene that is associated with aniridia, WT1. Because when you have a child with new sporadic aniridia, often that's from a deletion. And if the deletion is large enough, it hits the neighboring gene, WT1, and it predisposes to Wilms tumor of the kidney. And so for this situation, genetic testing is indicated, and we do genetic testing. There is a new large deletion that hits not only PAX6, but it's also its neighbor WT1. This child is at high risk for Wilms tumor, and indeed he develops Wilms tumor 1 year later. But following him carefully, we were able to pick it up quickly. So Wagner syndrome, that is the Wilms aniridia syndrome, Wilms tumor aniridia syndrome is one of the genetic syndromes you shouldn't miss. Here's a child with corneal haze sent for glaucoma surgery. I don't have pictures of his corneas to show you, but I do have pictures of his face. And because of his appearance, we asked some more questions, and indeed the child had had recurrent upper respiratory infections. The child had joint laxity. This child has facial features consistent with mucopolysaccharidosis, glycosaminoglycan deposition in multiple tissues. And indeed, he didn't actually have glaucoma. He had storage glycosaminoglycan deposition in the cornea, causing corneal haze, mistaken as congenital glaucoma. Now, these children can develop glaucoma as they get older, but usually they don't have it at this early stage. And mucopolysaccharidosis is one of these conditions that often goes undiagnosed for many years, but ophthalmologists are key in diagnosing this subset of conditions because several subsets of mucopolysaccharidosis are associated with corneal haze. It's not trivial to pick these up because there are enzyme replacement treatments for certain types, and the earlier these children are diagnosed, the better. Here's another child who was referred as suspected glaucoma, who also had undiagnosed MPS, mucopolysaccharidosis, one of the genetic syndromes we shouldn't miss. Here are 2 children referred with ectopia lentis. The slide just went off here, but I can still see it over here. They're both 7 years old, and they both referred with ectopia lentis, and they have 2 different causes. The child with in the upper left-hand corner, he has lens subluxation superior temporally, and the zonules are visible. He has very flat corneas. This child has fibrillin mutation. Now, any child who comes in with obvious Marfan syndrome, I think we would be able to pick up easily, but it's important to remember, it's important to realize that children can present with ectopia lentis from fibrillin mutation without any signs other than ectopia lentis, and they're still at risk for progressive aortic dilatation. So we have to rule out fibrillin mutation in any child who comes in with ectopia lentis. The child in the lower right, presented with the lens in the anterior chamber, came in with angle closure glaucoma. This patient has fragmented zonules. This child has a classic presentation for undiagnosed homocystinuria, CBS-related homocystinuria. These children are important to pick up because early dietary management can prevent mental retardation. They also have a predisposition to thrombosis that's important to identify as well. So 2 conditions important to pick, not to miss, are Marfan syndrome and homocystinuria. Every child who comes in with ectopia lentis we have to document why we don't think it's one of these conditions or refer to someone who can do that. Here's a 3-year-old girl referred with low vision, nystagmus, abnormal head position. We do a good exam. We diagnose the child with oculocutaneous albinism. But we're not done yet. We have to ask some pointed questions. And when we ask pointed questions, we do find that this child has easy bruisability. This child has a bleeding diathesis. This child has undiagnosed Hermansky-Pudlak syndrome. This is not uncommon in the region, Hermansky-Pudlak syndrome, and it's important to pick these children up, not only for their bleeding diathesis, so they're managed appropriately, but because they also have a risk for progressive fibrosis of different organs, best treated when diagnosed early. Here's a 7-year-old girl referred with decreased vision. She has lens opacities. Those lens opacities are not visually significant. She also has posterior subcapsular cataract. That's causing the decreased vision. But these are acquired lens opacities. This is an acquired juvenile cataract. And whenever you have an acquired juvenile cataract, you should be on alert for possibility of metabolic disease. And this child, indeed, when we do further questioning, had intractable diarrhea. She has an older sister who had juvenile cataract, and then as a young adult developed mental deterioration and had to be institutionalized. This girl and her sister have undiagnosed cerebrotendinous xanthomatosis. This is a diagnosis you might not have heard of before, but it's important for us to know about because these children come to us with juvenile cataract, we treat them, and then 5-10 years later they start to have mental decline because in this disorder of cholesterol metabolism, there's progressive deposition in all organs of the body. It starts off in the lens, then it goes on to the brain, and it is treatable in early childhood. Cerebrotendinous xanthomatosis is a diagnosis we have to consider in any child who comes in with juvenile cataract to prevent their mental decline. Finally, here's a 3.5-year-old boy referred with low vision. He has nystagmus, photophobia. He has a cone rod dysfunction. Any child who comes in with a retinal dystrophy, we have to be a bit on alert because retinal dystrophy can be the first sign of systemic disease. This particular child, because of his retinal phenotype and his obesity, that deserves a pointed question, and sure enough, he had a history of transient cardiomyopathy. This is classic for Alström syndrome, and he does indeed have Alström syndrome. Alström syndrome is one of the ciliopathies. These are diseases that affect the cilia, the non-motile cilia. The photoreceptors have modified non-motile cilia. So this group of diseases affects multiple organ syndromes and often the retina. There are different names attached to these syndromes depending on what organ systems are involved. The names are not important, but what's important is to realize there's a high risk for renal failure in many of these patients, and any child who comes in with early onset retinal dystrophy should have genetic testing to make sure they're not at risk for systemic ciliopathy. So that brings me to the end of my time. I've gone over some genetic syndromes you shouldn't miss. The thread that ties these syndromes together is that they present first to us as pediatric ophthalmologists, often without the diagnosis, and early diagnosis decreases morbidity and mortality. Thank you.